COVID-19. Next slide. I have no disclosures or that I'm going to use off-label use and investigational use during the presentation. On the top four, you see the seasonal coronaviruses that circulate in the winter and the spring, usually cause very mild disease. On the bottom, you see the three zoonotic coronaviruses that Mario was referring to. And the one that we're going to be talking about today is the SARS-CoV-2 cause of the COVID-19. Next. So just to put things in perspective, SARS-CoV, next. Over 8,000 cases worldwide, mostly in China, with high mortality, but we only got 41 cases in the US. Next. MERS-CoV, very high mortality, but thankfully the infection was mostly, the spread was mostly confined to Middle East, only 2 cases in the US, and SARS-CoV-2 with nearly 400,000 cases within 3 months and significant mortality. Next. So these are the numbers as of yesterday. Very rapid spread of this virus. Just to put things in perspective, the first case of SARS-CoV-2 in the US was in Seattle in January 21st. And within 2 months, we have more than 40,000 cases. Next. So most of these patients present in their 50s. This is not an infection of young people. Only less than 2% of the cases occur in people who is 19 and younger. The incubation time is usually around 4 days, but it can be as long as 14 days. Many of these patients do not have a known exposure, especially as we have community spread. And these are the symptoms for hospitalized patients with COVID-19. Fever is almost universal, but be aware that up to half of the patients might not have fever on presentation. Cough, which is mostly a dry cough, and shortness of breath are the second and third more common symptoms. On the right side of the slide, you see the timeline for the COVID-19, and you can appreciate how it might take up to a week from the onset of symptoms to development of shortness of breath and dyspnea. So these patients might look okay to you, tolerating room air or nasal cannula, but within a couple of days, they might decompensate really quick and progress to ARDS, the ones that are going to progress. Next. These are the most common laboratory findings. Lymphopenia is common. This is not specifically a CD4 compartment lymphopenia, but an overall lymphopenia. Transaminitis seen up to in a third of the cases. And as you can see there from the slide, a very pronounced inflammatory response. Half of the patients will have high interleukin 6 levels and high CRP levels. On the right side, I have information about PCR detection of this virus. The viral loads are higher in specimens collected from the nose compared to specimens collected from throat. And the median time of shedding is around 3 weeks for survivors, but it's been reported to be as long as 37 days. Viremia occurs in up to 15% of the cases, which raises concerns about transmission of the virus via blood products or transplantation. And the virus can be detected in the stool in half of the cases, regardless of diarrhea. Next. This is the most common CT findings. On the right side, you see ground glass opacities bilaterally typically. More than half of the patients have an abnormal X-ray, but nearly 90% will have an abnormal CT. More organized consolidations, like the picture in the middle, can be seen, and also thickening of the interlobular septa, as you see in the bottom. Next. These are the complications for patients with COVID-19. For hospitalized patients, so up to a quarter might require ICU care for treatment of ARDS and shock. Oxygen supplementation is required in the majority of patients, but only a minority will require mechanical ventilation. And these patients are not difficult to ventilate. As you can see, only 1 to 3% will require ECMO. So most of these patients actually end up dying from other complications while in the ICU, because they have an average stay in the ICU of 8 days. And this is where they might have cardiac complications, superimposed infections, or cytokine release syndrome. As you see on the panels on the right, patients who died or do poorly with this infection have very pronounced inflammatory response, very high D-dimers, interleukin 6 levels, very high ferritin, and troponin leak. Next. The mortality rate among hospitalized patients is being reported in the range of 1 to 4%. In the US, it's in the range of 1.2%. But we don't actually know the mortality for this infection because the denominator must include asymptomatic and subclinical infections. Among hospitalized patients with pneumonia, it's a bit higher, up to 15%, but extremely high in patients admitted to the ICU critically ill. Half of those patients might die. An important factor determining mortality is the age group you are dealing with. So again, patients who are 19 and younger, essentially mortality is 0, but it starts increasing stepwise as you go by decades, around the range of 3% for those in their late 50s, up to 5% those in the early 70s, and extremely high, 20 to 27% in those 80 and above. Most of the cases of ICU patients and most of the mortalities have been seen, events have been seen in patients who are 65 and older. Having said that, we have 2 patients in Tower intubated with COVID-19 and they are in their 40s. So it can affect all the age groups. Next. This is a model proposed for the pathogenesis of this virus. On the left, on the stage 1, you see the viral replication causing flu-like symptoms and some mild abnormalities in the labs. Most of the patients will just not progress from this phase, but 20% will progress into a stage 2, which is the pulmonary phase, when you have hypoxia, PF ratios decreased, and you start seeing a very pronounced inflammatory response that ultimately might lead in a minority of patients to stage 3, the hyperinflammation stage, when they have full-blown cytokine release syndrome with ARDS, multi-organ failure. And these are the patients in the latest stage, stage 2B and stage 3, that might benefit from anti-inflammatory therapies. Next. So most of the patients thankfully present with only mild or moderate disease, flu-like symptoms, and maybe pneumonia on X-ray. Only 14% of them will actually progress to significant respiratory distress with hypoxia, tachypnea, or progressive infiltrates on X-ray. And only 5% of them actually have critical stage with respiratory failure, multi-organ failure, septic shock. Next. So we do not have any currently available effective and safe therapies for this virus. On the left, you have in vitro data for chloroquine preventing infection with SARS-CoV-2 in a human cell line. And on the right, you have recently published data in vivo for a small cohort of patients on the intervention group. And you can see how in the green line by day 5, 100% of the 6 patients who received a combination of hydroxychloroquine plus azithromycin became PCR negative within 5 days of therapy. Hydroxychloroquine alone was also effective at shortening the time to negative PCR compared to controls, but very small study has to be interpreted with caution. Next. Tocilizumab, an interleukin-6 receptor inhibitor, has also been shown to be effective in small non-controlled studies. This is a report of 21 patients who were hospitalized with moderate and severe COVID-19. Most of the patients received a single dose tocilizumab. A few of them received 2 doses. And you can see on the right how they all experienced very rapid improvement in CRP, inflammatory markers, temperature curve, and oxygen requirements. And on the left bottom, you see some improvement on safety findings as well. So showing a lot of promise for this type of intervention, but more studies are needed. Thanks. Next. So most of the institutions who are currently doing is only supportive care for mild cases. But remember, very close monitoring because these patients might get very sick by the 2nd week of illness. Those with pneumonia or moderate disease end up getting most of them hydroxychloroquine with or without azithromycin, being aware that the data for the combination is very weak, and the combination can increase significant prolongation on the QT interval and AKG. Those with severe or critical disease are the ones that might need to be enrolled in the trial for remdesivir. Meanwhile, you wait for the patient to be enrolled, or if the patient doesn't qualify because they have a strict exclusion criteria, you might attempt hydroxychloroquine plus or minus azithromycin. And these are the patients that might benefit from single dose tocilizumab. Some bullet points just to conclude. Next, we have no approved treatments or efficacious treatments for this infection. Corticosteroids are discouraged by both the WHO and the CDC, except on special circumstances. HIV protease inhibitors, the data with the trial published last week in the New England was very disappointing, although the study was underpowered, and then the randomization occurred 2 weeks into the onset of the disease. Next. Role of HIV is controversial. Intravenous immunoglobulin is controversial because we haven't built herd immunity against the virus yet. Next. There is another talk on this topic, but there is no data for ACE inhibitors or ARBs. Next. Most of the patients in China receive Tamiflu for no good reason. There is no reason to believe it works and should be reserved for patients with influenza. Next. And 90% of the patients in many of these studies receive antibiotics, and we do not recommend prophylactic antibiotics unless there is a clear indication. Next. So there is really no treatment for coronavirus, so you have to work on prevention. Next. So wash hands and practice social distancing. Stay home, stay safe. Thank you.
All right, we'll go ahead with the next topic, and we'll discuss what is the risk of cardiovascular disease in this pandemic of COVID-19, and learning from some of the international data. Discuss some of the current data that we have from internationally and also the U.S., and compare some of the prior viral illnesses, in particular influenza, and what does that tell us a little bit about the current mortality that we're seeing with COVID and coronavirus. And finally, we want to touch upon and formulate a strategy during this pandemic for the use of ACE or ARB in patients with hypertension, heart failure, and other indications such as ischemic heart disease, because there's been a lot of uncertainty around this topic for the reasons that Dr. Stevenson and Dr. Camargo highlighted, and we'll touch on that in a second. Next slide. So as you all know, this is a worldwide pandemic, and the current numbers as of last night show that 400,000 people worldwide have been confirmed infected, and there's more than 18,000 deaths. This represents about 4% mortality based on those numbers worldwide. Next. The U.S. data is similarly showing increases in the numbers over the past week. There's been 55,000 cases in the U.S. now, with 790 deaths, and some areas, such as New York, are really suffering the wrath of this virus. Next. And our most recent local data, there's about 1,400 cases in Florida, and about 300 and change cases now in Dade County. So it's hitting us all equally. Next. Next. So going back to some of the data that initially came out of China, this is from their initial 2 months of experience, and they published this in New England Journal last month. What you see is that out of about 7,000 and change hospitalized patients in China, 1,000 or so met the primary composite endpoint of ICU admission, mechanical ventilation, or death. The death rate was about 1.3%, and if you look at comorbidities, there was a relatively high risk of comorbidities. Diabetics were about 7% in the overall patient population, but there was a nearly threefold increase in the patients that met the primary composite endpoint. So similarly with hypertensive heart disease, we saw a nearly 2 to 3-fold increase in patients that had adverse outcomes. Patients that had coronary disease, it was low in the overall patient population. About 3% of patients had coronary disease, but those that had bad outcomes had more coronary disease and similarly more cerebrovascular disease. So we understand that our cardiovascular patients and cerebrovascular patients are at increased risk of having adverse outcomes related to SARS-CoV-2. Next slide. And this is corroborated by further data. And there's a larger subset from the China CDC data set through February, 72,000 patients diagnosed and suspected with COVID-19. And what you see is that in patients that died, there was a much higher representation of cardiovascular disease. And the case fatality rate in patients with underlying cardiovascular disease was above 10%, which is nearly tenfold higher than the case fatality rate overall. So we know our patients are at increased risk with hypertension, cardiovascular disease, and diabetes. Next. Similarly, what we see in the Italian experience is that the overall mortality rate was much higher, 7.2%. And compared to China, this has been theorized that it could be related to the population in Italy. 23% of patients are over the age of 65, and the mortality rate is therefore higher in the Italian cohort. If you look at the age strata, there's across the Italian and Chinese cohorts, they're similar in terms of mortality. And a chart review of about 355 fatal cases in Italy showed a high prevalence of heart disease, including ischemic heart disease, diabetes, and cancer as well. Thus, the age and related comorbidities can explain, at least in part, some of these increased adverse outcomes. Next. And this is just a graph further highlighting the difference based on age strata. If you look at the age strata, there's essentially no difference between Italy and China, but the overall representation of the higher age strata, 65 and above, was much higher in Italy, which can account for the case fatality rate. Next. So how does the SARS-CoV-2 virus affect the cardiovascular system? And we're still learning about this as we go through this pandemic. But what we do know is that it can really lead to acute cardiac injury, which is usually manifest by elevated cardiac biomarkers, troponins, and pro-BNP. And if you look at non-survivors, the cardiac injury is much higher. As almost 59% of non-survivors had some elevation of troponins or biomarkers. And the mechanisms that could be varied. They could be direct toxicity through viral invasion. They could be related to demand ischemia and acute coronary syndrome, or it could be cytokine mediated and related to a stress cardiomyopathy. And any one of these mechanisms could be working. There are some reported cases of myocarditis and pericarditis given the ACE2 expression in the cardiac cells. Arrhythmias, and this doesn't stratify different types of arrhythmias, but arrhythmias were noted in about 17% of hospitalized patients in the Chinese cohort. And if you look at heart failure and or shock, about a quarter of patients have some degree of heart failure. And a much smaller percentage, but some patients do proceed to develop shock. That could be related to cardiac shock or cytokine storm and ARDS with multi-organ failure. So the initial experiences of some recent publication out of Washington that there was 21 patients that were critically ill. And out of those, about 49% had pre-existing heart failure and 7 developed cardiomyopathy. And Dr. Hare discussed some of this data earlier this morning in the Topics in Cardiology session. So next slide. So, and we know historically that viral infections such as influenza can lead to increased incidence of acute coronary syndrome. After influenza, we see there's a 6-fold increase over the first week of acute myocardial infarctions. So this is not unprecedented data. Next. So why are our heart patients vulnerable in the era of COVID-19? And is there anything that we could do? And are we placing our patients at increased harm, particularly with some of the medications? And that's really one of the questions that's kind of popped up over the past 10 days, 2 weeks. And a lot of the professional societies have really gone to great extremes to try to answer some of these questions. Next slide. So it's really all about the ACE connection. And so we're going to have to do a little bit of detective work, to go back and review the renin-angiotensin system and what's the data that we have and what's the potential harm with ACE inhibitors and or ARBs. So next slide. So if you go back and remember the ACE renin-angiotensin aldosterone system, our current understanding is that ACE, there's 2 isozymes. There's ACE1, ACE and ACE2, which we know have differing responses to the cardiovascular system. The angiotensin converting enzyme inhibits the conversion of angiotensin 1 to angiotensin 2, which therefore inhibits vasoconstriction, hypertrophy, and fibrosis, and is beneficial process, and therefore is the basis of the use of ACE inhibitors and/or angiotensin receptor blockers in patients that have hypertension, risk factors for cardiovascular disease such as diabetes or established cardiovascular disease and ischemic heart disease. But we know that the ACE2 pathway also exists, and the ACE2 pathway has been theorized or has been shown to actually be in many ways beneficial by cleaving angiotensin 1.9 to angiotensin 1.7, which has a protective effect. It has an antihypertrophic effect, antifibrotic, and a vasodilatory effect, as well as an antioxidant effect. And we know that the ACE inhibitors work on the ACE pathway, but do not work on the ACE2 pathway. Next slide. So what's the concern, and what's the theoretical concern? Well, as Dr. Stevenson mentioned, the SARS-CoV-2 spike glycoprotein uses the ACE2 receptor as the entry point into the cells. And these are expressed in lungs, intestine, kidney, as well as blood vessels. And so the concern is that by overexpressing ACE2, we can actually potentially put patients at increased harm and/or risk of developing the infection, and consequently also risk of having worse infection in case that they're maintained on these medications. Next slide. However, what we do know in regards to ACE2 is that the activity is not prevented by ACE inhibition. Again, ACE inhibitors work strictly on the ACE1 protein. And ACE2 does contribute some cardioprotective effects, as well, as we mentioned. And they play a critical role in regulation of cardiac function. In fact, ACE2 null mice have been shown to exhibit a phenotype of cardiomyopathy with LV dysfunction. So we know that ACE2 is a beneficial pathway in many ways. And selective blockade of either the angiotensin 2 synthesis or activity induces increased ACE2 expression. So ACE inhibitors and both ARBs increase ACE2 expression, and that's the concern that maybe we're granting the virus easier access to the cells. Next slide. But the animal data also suggest a potential protective effect, as we mentioned, cardioprotective and pulmonary protective, as there has been some data with some angiotensin receptor blockers that can increase ACE2 expression in the post-MI phase. And this is all animal data, mind you, so it's important to keep in mind. And SARS-CoV-2 binding to ACE2 leads to downregulation and excessive production. The theory is that of ACE2, which can contribute to lung injury and pulmonary vascular permeability. And therefore, while it seems paradoxical, higher expression of ACE2 may actually provide some degree of lung protection. Next slide. So what we could say, to summarize the data on ACE inhibitors and ARBs, the ACE2 receptor does allow entry to the virus into the cells, and its full-length form is a membrane-bound enzyme, while it circulates at lower levels in a soluble, shorter form. The ACE inhibitors, however, do not act on the ACE2 receptor, as they are completely different enzymes. And angiotensin receptor blockers may upregulate ACE2, but the evidence is not fully consistent. Not every ARB has been shown to have the same effect, and also it's organ-specific and tissue-specific, so it's not consistent. Next. So what about cardiovascular comorbidities in SARS-CoV-2, and can we compare that to other viral infections, in particular influenza? Next slide. So what we do know is that looking at the last pandemic from about 10 years ago, that was the H1N1 flu, there was an estimated 60 million cases in the US, 274,000 hospitalizations, of which 12,000 patients were estimated to have died. And if you look at that, the difference between that pandemic and this pandemic is that it seems that the majority of the deaths in the H1N1 occurred in younger patients and not the older patients that we typically see with seasonal flu and with our current epidemic of COVID. Next slide. But if you look at seasonal influenza and pneumonia-related deaths in the US over the same course, and so this is our data during this ongoing season, and we see that we're averaging about 400 to 500 deaths on a weekly basis and related to influenza illnesses. And if you add up the pneumonia-related deaths, that's another 3,000 per week. So influenza and pneumonia, still remains a major, player. Next slide. And if you look at those patients, what we see is that there's a high comorbidity. The majority of these patients that die are elderly, above the age of 65, with a high burden of cardiovascular disease. Nearly 40% of patients have some degree of cardiovascular disease, and diabetes is represented equally high. 30 to 40% of patients have metabolic disorders, as well as chronic lung disease. So we know that the comorbidities do put our patients at risk. Next.
1 minute, Carlos.
Yes. Oh, I'm sorry?
Try and finish up in the next minute or two.
Yeah, sure, definitely. So, this is the crux of the problem. And so, should we discontinue ACE inhibitors given the uncertainty of their effect in SARS-CoV-2? And what we see here, this is the data with ACE inhibitor discontinuation. So, if you discontinue ACE inhibitors, you see over 90 days there's a nearly twofold increase in mortality. So it's not a benign question to discontinue ACE or ARBs in our at-risk patient population. Next slide. And similarly, in readmissions and mortality and readmissions, there's increased events with discontinuation of medication. Next slide. So based on that, the recommendations based on from various national and international societies is that we should not discontinue ACE inhibitors or ARBs during the COVID pandemic because of the uncertainty and because of the increased risk that our patients may suffer from their underlying cardiovascular disease. Next slide. So in summary, what we can say is that while the burden of cardiovascular disease is high, we don't understand fully the burden of the virus on the cardiovascular system. There's no data to suggest ACE inhibitors or ARBs increase susceptibility or worsen the infection. And therefore, we should not discontinue ACE or ARBs for our patients that have other indications. And we should manage the use and discontinuation of these medications based on purely clinical basis, i.e. kidney injury, hypotension, shock, etc. So next slide. So I think that there's some potential for future research, whether it's animal data, studies using cell lines, and large registry data from China, Italy, and the US, and so there's potential for future data. Next slide. And for those of you who are interested, our colleague, Dr. Murray Epstein, is going to host going to be publishing an AHA editorial on this subject, and this should be online in the next couple hours. It'll be released at 2 p.m. later today. And thank you for inviting me to talk on this.
Carlos, that's great. Thank you so very much. We'll continue with Dr. Greidinger. And then if there's time at the end for questions, I appreciate everybody's comments on the chat line, and keep them coming, and we'll figure out a way to get them answered to you.
Next slide, please, Laura. So there's been a lot of discussion of ibuprofen in COVID-19 infection. British Medical Journal observed in their news that there was the opinion, say, quote, doctors and scientists, that ibuprofen should not be used for managing symptoms. And if you look at the details in the clinical recommendation protocol published both through Jackson as well as through University of Miami, the last several times I've looked at it, I've seen this quotation as part of our recommendations. Although not scientifically proven, it is hypothesized that ibuprofen can increase ACE2, which SARS-CoV-2 uses to bind. Therefore, ibuprofen may worsen the clinical picture, scientific evidence pending, with this citation. Next slide. In response to the article that was cited and the concerns in British Medical Journal and elsewhere, the World Health Organization stated a contrary view, that they do not recommend against the use of ibuprofen based on the fact that there's no clinical data to support this. So given these conflicting views, where does the truth lie? Next slide. So first, here at the top of the slide, this is the actual citation for the article that was in our recommendations. Notice that it's not from Lancet. It's from Lancet Respiratory Medicine. And here is an extended quotation from the article, which in a single line states, without any evidence in the article to support this, no clinical or laboratory studies done, that ACE2 levels can be increased by glitazones and by ibuprofen. And the authors therefore hypothesize that treatment with these ACE2 stimulating drugs might be associated with worse outcome in COVID-19. Next slide. So backtracking to what Dr. Stevenson discussed, the evidence that ACE2 is a receptor for COVID-19 is largely based on this study published in Nature, which took HeLa cells. So these are papilloma-infected cervical cancer cells, which do not natively express ACE2, and transfected them with ACE2 protein, and then saw that the cells that were transfected with ACE2 protein were then able to uptake virus. So there are no studies in COVID-19 looking at actual target tissues for whether ACE2 is a receptor or the receptor that's involved. And there's been a great deal of emphasis on the fact that the recognition by coronaviruses of their receptors is glycation dependent. Typically, sialic acid residues are important. And there has not been any published discussion of either the glycation requirements for COVID-19 infection or whether there's variation in the sialadination or otherwise glycation of ACE2 in different tissues in which it's expressed. Next slide. There certainly is evidence that ACE2 is expressed in the lung, particularly in type 2 alveolar cells, and it is, however, only on a small subset of these cells where actual infection appears to occur, both in COVID-19 and in SARS. Next slide. So in SARS, there are at least some reports that suggested that the affinity of the viral spike protein for ACE2 is potentially higher than the affinity of the spike protein for ACE2 in COVID-19. There have been reports demonstrating direct infection of type 2 alveolar cells in SARS, but there have not been demonstrations that all of the different kinds of cells throughout the body that are ACE2 expressing uptake the SARS virus and are targets of infection. Moreover, it's been reported that some cells for which no evidence of ACE2 expression occurs can also be targets of infection. And the effects of ACE2 levels on the risk of infection and the severity of infection are unknown. Note, as was discussed by Dr. Alfonso, that ACE2 can exist as both a membrane-bound and a soluble form, and I'm not aware of any studies that have looked at the extent to which the soluble form of ACE2 can bind to these coronaviruses. Of course, if the soluble form can bind, and if increasing soluble ACE2 is an outcome of increasing overall ACE2 levels, then soluble ACE2 could be a very effective inhibitor of uptake of virions by ACE2 or other potentially susceptible cells. Next slide. So what is the evidence that ibuprofen, or any nonsteroidal for that matter, increases the expression of the ACE2 protein? There is a single citation in the literature, specifically with the use of ibuprofen, looking at cardiomyocytes in rats. There are no studies in humans. There are no studies with other nonsteroidals. So there's a fairly substantial amount of guessing that's underlying the assumptions in the recommendations that have been provided. Next slide. And in fact, the authors of the report, which is cited in our clinical guidance, who are based at the University of Basel in Switzerland, have now published a semi-retraction of their opinions on the University of Basel website, saying that there is no clear evidence of an adverse impact of ibuprofen use in COVID-19 infection, and that what they had mentioned in their article in Lancet Respiratory Medicine was expressly formulated as a hypothesis aimed at scientists with a view toward further investigation, and does not constitute a recommendation to use or not use certain drugs. Next slide. So with that in mind, it's important to recognize that nonsteroidals are in general bad for people who are sick. They increase the rate of GI bleeding, more so with age and with various comorbidities. They have adverse effects on kidney function, increased risk of cardiovascular death events, as we learned about last week. They're associated with increased mortality. In patients with triad asthma, they can increase the risk of bronchospasm. And particularly in adults, there are relatively few long-term benefits that have been documented in any clinical scenario with nonsteroidals in general. A couple, including the potential for nonsteroidals at high dose to have disease-modifying effects in seronegative spondyloarthropathies and to prevent polyposis in individuals at risk, for instance, in colon polyposis. It's also important to emphasize that although nonsteroidals have anti-inflammatory effects, they do not have immunosuppressive effects. There are some lay papers that one can find where individuals were claiming that nonsteroidals should not be used because they would prevent the body's immune response to COVID-19 infection. And there's no evidence in any infectious disease that I'm aware of for a nonsteroidal having that effect. Next slide. And I welcome questions.
Well, I thank all four presenters today for doing an absolutely splendid and succinct job in reviewing what is obviously very recent literature, and the slides and presentation will be available on the website for others to view. If you're not one of the 260 people that actually viewed this live or came late, so that will be available. And then, as I said, the questions that were posed on the chat will be broken down, sent to the specialists, and then made available with their answers on the website, hopefully in the next day or so. If anyone has an urgent question now for any of our speakers, please feel free to type it now, because I can't review all the chats that have gone on. Okay, Dr. Brown, do we have a QR code? What do you mean by QR, Dr. Brown?
No, we don't, Dr. Brown.
Oh, for the MOC. Well, at some point, we'll get the CME credit, but we may not get the MOC credit. We'll have to work on that. I think the advantages of this grand rounds far outweigh any the CME, although I understand people have not been able to sign on by the CME site. We'll have to work that out. Anyway, I thank everybody.
I'm so sorry to interrupt. I just want to make a point. Originally, the site for faculty was not working. They did fix it. A little late, but they fixed it.
So what is so if we sign on now, we'll get the MOC credit through that?
Yeah, so that would be up, and then people can also do the Enduring as well. Once we finish here, I'll have the recording uploaded.
Thank you. Okay, well, I'll conclude today's Grand Rounds and look forward to seeing you all next week. Everyone, please stay happy and healthy. And if we can help you in any way, let us know. You'll look for an announcement for other faculty meetings this week for updates and so forth. But again, thank all our presenters for doing such a splendid job on such short notice, and Dr. Deshpande and Laura Pinzone for organizing it. Thank you.